Welcome everyone to this presentation, What Keeps Your Hospitalized Patient Up at Night? Very excited to welcome Rosie Bartel and Daniel Ritchie to share with us their program. So I'll turn it over to you and you just let me know when you want me to advance the slides.
Perfect, thank you. Hello everyone, I'd just like to start out and thank you all for the opportunity to talk to you today. I know both Rosie and I are excited to talk with you about our presentation, What Keeps Your Hospitalized Patient Up at Night. Libby, you could go ahead and advance the slides, please.
Great.
All right, so just a couple of objectives for today. So I will talk briefly about the relationship between healthcare associated infections and environmental cleaning. And then Rosie will take over and talk about the use of patient stories to guide research and learn how this patient-guided research can be translated into practice. We can go ahead and advance the slides. All right, so I just wanted to start out and talk a little bit about myself, my roles, my background, and my goals, and then I will touch very briefly on the healthcare-associated infections. So first and foremost, I'm a community pharmacist. And I have worked in an independent community pharmacy since I graduated from pharmacy school. And I love being a community pharmacist. And the thing that I really value about it is that every day I work, I get to interact with patients, and I get to, well, not in the same way as I used to with the current pandemic, but I get to interact with patients and develop relationships with them and really build those relationships over time. And so I've always been very interested in kind of the power of relationships and the value that they bring to the healthcare system. So with that experience, I years ago joined the University of Wisconsin in a graduate program health services research in pharmacy, and I have been in that program for a number of years now. I received my master's from that program in 2018, and I'm currently in the process of writing my dissertation. So kind of through the experiences I've had as a pharmacist, and then the kind of the research lens of being in graduate school, it's become very clear to me that kind of the patient perspective is something that rings true through both like healthcare practice traditionally, as well as research for improving healthcare. And so it's become a big focus of mine. And I was really fortunate at the beginning of this year in January, I was brought on, I started working with a group of infectious disease researchers at the university. And the group that I work with, we do research, both clinical trial research as well as social and behavioral research. And the research group is under the direction of Dr. Nasia Safdar. And we have researchers that are both on the UW, the University of Wisconsin side of things, as well as the Madison VA, the Veterans Hospital side. So in joining them, I have gained a role on each of our legs, if you will. And so on the UW side, I am the engagement director for our infectious disease focused patient engagement group. And this is how I came to know Rosie. So Rosie is the patient and caregiver coordinator for this group. And so I've actually only met her back in January of this year, but she has been with the engagement group since its inception in 2017. And it's a pretty interesting story. The group was founded in 2017 as part of a PCORI grant, and the grant was focused on setting a patient-centered research agenda for infectious disease research. And it wasn't a very big grant, so when the funding for the grant ran out, Rosie and Dr. Safdar realized the value that the patient's perspective was in research. And so we've been fortunate enough, we've actually held the entire group effectively on retainer and we use them. We basically consult with them on pretty much all of our research whenever we can, and we've done so since that grant was finished. Um, and so then on the VA side of things, this is my role on the VA side is I am the Veteran Engagement Ambassador for the Madison VA. And this is a new position. We don't actually have an engagement group of veterans yet. However, in 2019 in January, the VA system nationally put in a mandate that requires for all research that is to be funded by the VA that that veterans need to be involved in from the beginning in terms of design all the way to dissemination of the results. And so to help address those needs, I was hired to create a veteran engagement group. And fortunately, we got a administrative supplement approved just 2 weeks ago. That's going to give us the funding to start moving forward with that. So um, I'm really excited, and kind of because of that. So then my goals are I want to create a engagement group that has veteran representation that is accessible to the providers in the VA as well as the University of Wisconsin more broadly. So now we can change gears a bit, and I'll move into the healthcare associated infections and environmental cleaning, so we can go on to the next slide. Okay, so for those that do not know, a healthcare associated infection is an infection that occurs while you're receiving care for another condition. And so, for example, a patient may be admitted to the hospital for pancreatitis, and throughout the course of their care, they may develop a pneumonia while in the hospital. And so this would be an example of a healthcare associated infection. And these infections can occur at multiple different facilities in addition to just hospitals. So ambulatory surgery centers, dialysis facilities, outpatient care, as well as long-term care facilities. We can move on to the next slide. So I think the key with these HAIs is a couple of things. They're very serious, they're very common, they're very costly, and they're very preventable. So they're so common, in fact, that approximately 1 out of every 31 hospitalized patients will be affected in some way by a hospital or a healthcare associated infection. And this results in approximately 1.4 million infections annually that are caused by people seeking care for other needs. And out of those 1.4 million, approximately 90,000 people die each year in the United States from these infections. I think it's very important to underline that death is not the only negative consequence that occurs from a healthcare associated infection. So many of the people that are affected by this continue to deal with the condition for years, and it changes their life dramatically, as some of you may know about Rosie's story, and others will learn about shortly. In addition, these are very, very costly. So it's estimated that these cost somewhere between $28 to $45 billion annually, the direct cost of them. And sadly, they are been shown to be highly preventable. Anywhere from 20 to 70% of infectious healthcare acquired infections could be preventable. So we can move on to the next slide. I also want to say that I am not an infectious disease expert. I am also not a environmental cleaning expert, but we do have experts in those fields on our team. And so at the end, if there are people curious to know more about that, I can connect you with the appropriate individuals. So environmental cleaning. So one of the ways in which these hospital-acquired infections are spread is due to contamination of the hospital itself. And so there's been associations between previous occupancy by a colonized patient or an infected patient, as well as contact with frequently touched surfaces throughout the hospital. And so with this in mind, the transmission occurs between primarily two pathways. So one is contact with surfaces. So there are the contaminated surfaces, and then also patients are touched by healthcare workers that are doing procedures on them. They are touched by other caretakers and visitors, and it is possible that the surfaces that those individuals have touched before reaching the patient or after can contain these infectious pathogens. Next slide, please. All right, and then this is just a kind of a visual representation of how these pathogens can spread and where environmental cleaning fits into the prevention strategy. So you have colonized patients. These patients are in rooms and they also touch surfaces like handrails and elevator buttons and doorknobs and bathrooms and sinks. And so one of the ways in which this can be transmitted is through healthcare workers that come into contact with the patients. They enter the room to do procedures. So there have been a lot of interventions focused on hand washing and degloving and safety practices associated with the healthcare workers. So that would be the picture of the gloves in the diagram. And so that is one way that you can break the chain of transmission between the healthcare worker to the surface or the healthcare worker to a susceptible patient. And then the other way is by actually disinfecting the surfaces themselves. And so this is what we think of when we think of environmental cleaning. So this can prevent people from picking up the pathogen from a surface as well as directly transmitting it to susceptible patients. And what we know is that this type of an intervention, when bundled with other interventions, so like I mentioned, the hand washing and hand hygiene interventions, as well as education bundled with environmental cleaning, has been shown to decrease the spread of HAIs. In fact, in 2002, the rate of HAIs was 1 in 25, and now it's approximately 1 in 31. And so we know that these interventions work, but they've always been studied in kind of bundled approaches, and so there's definitely still more work to be done. And so with that, I will happily turn it over to Rosie so she can tell you all a little bit about her story. And we can go ahead to the next slide, Rosie.
Thank you, Daniel. And I have to tell you, I met Danielle in January, and I will tell you that I have adopted him as one of my sons. So he has become part of my life, and we talk often about lots of things. But he is definitely a gentleman who has got a lot to offer. My story is that I do not come to this process because I was involved in medicine or no medicine, but I come to you today as a patient who back in 2009 had what I would have considered an ordinary knee replacement that developed into a healthcare acquired infection, a MRSA staph infection, which is one of those infections that when you hear it, you cringe. And I can tell you that the day they told me I had a MRSA staph infection and I had less than I had a 30% chance of surviving it, was the day that I started down a path that is now 11 years old and still ongoing. My story is that I am a mother, a grandmother, and an educator. And as of this past July, I am now a widow. But I have to tell you that the man standing behind me in this picture is my husband, David. I lost him on July 28th to terminal cancer, but he is still pushing me forward to tell my story, and that's why I'm here today. My story is that I have had 55 surgeries. I've had over 200 hospitalizations. I've been septic more than 12 times. I have had over 100 blood transfusions. And this all has led me to have had my leg first fused. Then I had an amputation 6 inches above my knee, then an amputation of my total hip. and finally an amputation of part of my pelvic bone. I have learned during this time that there is many things that keep me up as a patient at night that didn't keep me up 11 years ago. I would have never thought about who was in that bed before me, but I do now. When I'm in a hospital bed, I always think about who was in this bed before me, what did they have, and how well was it cleaned after that person left the room. And it's not just those things, it's things like IV poles and blood pressure cuffs and closet door handles and countertops, all those things that, you know, even your tray, your hospital tray, all those things that a patient touches when they're in the bed, their bed rails, were they cleaned and how were they cleaned? And so that led me to thinking about that a lot and being also involved in a lot of things. And one of the things I was involved in was the Department of Health, Healthcare Acquired Infection Committee. And so this committee was formed to look at healthcare acquired infections. And one of the people on that committee was Dr. Nazia Safdar. And when she introduced herself the first time, she said she was from the University of Wisconsin and she worked in research. And I was like, this is the lady I want to know. Because one way of getting rid of healthcare acquired infections is getting to the bottom of them to make sure they never start in the first place. And so I started making sure that I got near her at meetings and she and I got to be friends. And she would always say to me, you and I need to do something someday. And we'd say that to each other and we'd agree to that. And one day she walked into the meeting and she said, Rosie, I need to talk to you before we leave today. And I said, okay. And so we talked and she said, we are applying for a PCORI grant. We need a patient to help us apply for the grant. And would you be willing to do that? And I said, sure. She said, we need a story and we need a patient story that has to do with a healthcare acquired infection. So I helped them write the PCORI grant. And in my world, I thought when we got a $250,000 PCORI grant, that was a pretty big PCORI grant. As Daniel said, it was a small PCORI grant, but I thought it was a big one. And so as we started to talk about how are we going to get patients involved in that, I said, I believe we need to bring together a group of people who are somehow connected to healthcare acquired infections. Either they have been involved themselves, have had it, or they've been a caregiver, or they have been involved as a nurse or a doctor in healthcare acquired infections. And so that's how we developed our support group. We call it our peer group. And we worked together. And as we looked at how to look at spending that $250,000, also researchers were looking at how to spend that $250,000. And they had formed a stakeholder group of how to spend that $250,000. As we looked at it, we talked about those things, about how rooms were cleaned and how infections were passed on. We knew that hand washing was being looked at and talked about a lot, but we didn't think environmental things were and room things were talked about enough. And there was a young man in our group, and he had been the caregiver for his brother who had been sick a long time as a cancer patient and had been in and out of hospitals a lot. And he talked about how he would go in and clean all the surfaces of the room to make sure that his brother wouldn't get an infection while he was in the hospital. And it rang true to us. And so that was how we thought we should spend the money. I know the researchers were looking at C. diff, and that was their thing, and that's where they wanted to spend the money. And stakeholders were kind of in the middle. So when we finally all came together, we all shared our vision to how to spend that money and how to do the research going forward. And as we told our stories and told why we wanted to spend the money the way we did, very soon C. diff took a very big back seat. We did put some money towards C. diff, but it took a very big back seat toward environmental cleaning. And so environmental cleaning took the forefront, and the money was put forward to looking at environmental cleaning and how could we better do it better, and how could we help environmental cleaners and people who work in the environment do a better job. And so we looked at what were some of those high touch places, what did they look like, and how could we better help healthcare workers look at that, especially environmental cleaning workers. And so we created a form, and I know that it's available to you. I think Laura will put it up on the website, in the chat room, a connection to it. But we created a form called the High Touch form, and it was a form that you could look at all those places in a room, and you won't, when you look at the form, you're going to think, I never thought of those places, but they are places that are touched daily by people coming in and out of the room. So I was the person who had that research. I was the person who knew about that research. And I was also the person who was working with hospitals at the time, and healthcare facilities. And so I started talking to the hospitals that I was working with and about that research and about what I was learning and about what we were talking about, and maybe how could that translate into practice. And so I had one hospital in particular say, Rosie, we really are interested in what you're looking at and thinking about. And I think you need to start working with our facilities and our health and our environmental service and our security people, because I don't think they connect what they do to the story of the patient. Next slide, please. Now, this is the motto of that hospital. It says, I will know you, I will show you respect, I will go with you on your journey, and I am here to help you. Now, I took that motto and I worked backwards and said, okay, I know that that motto probably is in the minds of every provider and every healthcare worker that works the front lines. But how is that motto sold and sent to that environmental service person, that person that we used to call the housekeeper? How is that person looking at that motto? How is that facility management person, that maintenance man, how does he live that motto? How does that security guard live that motto? How does that person that works in the sterilization room live that motto? And I have to tell you, if you've never been to the sterile room in your hospital, go to it. You might have a rude awakening, because I used to believe that everything that was sterilized in the hospital was sterilized. Well, if you ever go to a sterilization room in a hospital, you'll find out that there aren't a lot of rules for those rooms. And some of the people that work those rooms might be the lowest paid people in the hospital. So their reason for doing the job may not always be the right reason, and they might not feel like their job is valued. So I started looking at this motto and started talking to the people that were in charge of these groups. And they said, our people need to hear your story. And I think that if they heard your story, it might make a difference. So I first told my story to the facility management people and security people. So that meant that I had to tell my story at 7 o'clock in the morning at a hospital that's an hour and a half from my home. But I did it. I went there. What was funny about telling my story that day was, all of a sudden, about 5 minutes before I was to tell my story, I kind of looked up at the audience and didn't realize that everybody in the room except me was a man. And I now had a completely different audience than what I was used to. And I realized that I would have to tell my story in a little different way than I usually tell my story in order to keep their attention. Because these guys were having to come in before their shift to hear a woman talk about her story. and they didn't have a real reason why that story might be important to them. Why was I telling them about an infection? Why did that have something to do with them? So as I told my story and then talked about how, as I lay in a hospital bed, I might think about when was the last time the filters were changed in this room, especially when I would look up and could see dust in the vents around my room. Those kind of things would make me think, I don't know if filters are changed in this hospital real often. And so I shared my story, and I didn't know if that story made a big difference or not, but I thought I held their attention. Nobody got out their cell phone. No one, some people asked some pretty good questions at the end. So a couple weeks later, first of all, as I entered that hospital, all of a sudden maintenance men were coming up to talk to me. And that had never happened in my life. And people, maintenance men in the elevator would say, "How are you today? And how was your day?" And I'm, "What have you been up to?" And I'm like, this is interesting that maintenance men are talking to me. They are just on the elevator with me. And then as I got to talking to the facility management director, he said, "Rosie, I have a few stories to tell you." And the first story is that there's a man that works as a maintenance man here who probably says less than 10 words a day. And so he came to me and said to me, "We are having a problem in this operating room that the nurses and doctors keep putting a table in front of the air exchange. And I think that that's a problem. And I believe that that table needs to be moved, but it keeps ending up in front of the air exchange." And he said, "Rosie told us that it was okay to come and talk to you about these things." And he said, "I wonder what Rosie would say about this. I wonder what she would tell me to do about this." And, he said, all of a sudden I realized that your stories and telling them that they had the power to speak up really empowered them, that they really heard you. And then he said, and another young man who, knew that we were redoing our NICU unit and that we were, talking to people about, what should they do? He said, "I'd like to talk to people that are redoing the NICU unit because my wife and I had a child in the NICU unit and we'd like to share our story." And he said that would have never happened. They would have never came to me to share their story if you hadn't empowered them to say, it's important to tell the stories. It's important to hear the stories. It's important to know those things. One of the things I do when I talk to groups like facility or environmental services is that when I talk to them, I tell them two things. First of all, that they are healthcare workers. They are healthcare providers. They are healthcare professionals. They are as much a professional as the doctors and nurses. They have a job, and their job affects a patient as much as the professionals that they think get that title because they have degrees behind their name. They are healthcare professionals. And they have a right to speak up when they see something that's not safe, that may harm a patient, that they need to look at a room from the point of view of their point of view, not just let things build up and get messy in a room. And one of the other things I tell them is that when you leave at night, I want you to think of one person in your life that's very important to you. And then I want you to think about, would you want that patient to be a patient in this hospital tonight? And then as you walk to the hospital and as you do your job, you might do it differently. And I believe that that's true. I believe that that does make a difference and that people do have those moments where they realize that they are empowered. Environmental service people have a very tough job. I've spent as much as 30 days in a hospital room, same hospital room, and about MRSA staph infection people, they're stuck in that room. That means you don't leave the room. Well, things pile up in a room, and it doesn't mean that it always is the patient that is leaving things behind, but nurses and doctors leave things behind. And pretty soon you have clutter all over the room. And now the environmental service person has to come in and clean, and they don't know what they can move and what they can't move. And so they clean around it. And pretty soon they become the Swiffer people, kind of swift around with their Swiffers, first the duster and then the floor Swiffer. And then they leave the room because they aren't empowered to say, hey, that room is cluttered and I can't clean it. And so I say they need to live this model. They need to know that they're walking that journey with that patient just as much as the nurses and the doctors are walking the journey with that patient. And they're there to help them as much as every other person is. So when I was doing the presentation for environmental service people, before my presentation, they gave out the awards for people who did a special training. And part of what happens when they do this special training for environmental services, they get two things. They get a $500 bonus, and they get $1 an hour increase in wages. So many people do the environmental training for that reason. If you can get a $500 bonus and $1 an hour increase in your wages, you might go through a special training. And so as I wrapped up my talk, they decided to take a picture of the people who were part of that group. And so after that picture was over, a young man by the name of Eric came up to me and said, I had an aha moment while you were speaking. And yes, I took this training for two reasons: to get the bonus and get the $1 an hour increase. But after I've heard you speak today, that money doesn't mean anything to me anymore. Now I have a whole different reason for having taken this training, and the training has a whole new meaning for me. Next slide, please. And I'm sorry, I said Aaron, his name is Ethan. And can you guess who Ethan is? Ethan is the guy in the middle who had that aha moment. And that training that he got was just, completely changed for him. And he was like, he couldn't stand still. He couldn't figure out how to get out of there fast enough to try to look at his doing things differently. Next slide, please. The presentation that I did has developed into a presentation that I now do with the Director of Environmental Services and the Director of Facility and Security. And so we've done trainings for their hospital and for other hospitals in the area. And last year we sent in a proposal to IHI for their forum, and our proposal was accepted, and we did the training at IHI at conference, their forum in Florida. Anyway, when we did the presentation in Florida, Corinne put in a new slide that I hadn't seen before. And this is the slide that Corinne added. And this slide probably at that point put me almost in tears, and yet really said the truth of what really is the truth, is that the infection I received as the healthcare infection I have, we don't know how I got it. We'll never know how I got it. And that's not my focus. My focus is trying to make sure that nobody else gets it. But she said, everyone in the room needed to own that. Everyone that works in a hospital or in a healthcare facility needs to own those infections that people get. They need to hear the stories. They need to take note. They need to make the changes that are necessary to make sure that this doesn't happen again. They need to then go back to the researchers and say, how can we improve? How can we keep improving? One of the things that happened from the research Corey grant was that one of the researchers took that information and is now using it to look at environmental services across the country, and especially with VA hospitals. And, so I'm now part of her group and works with her in getting the information we brought together from that PCORI grant and moving it forward. So everything keeps going in a circle. And if the vision of PCORI and getting people involved in patient engagement in research has improved practice, and practice now pushes research to keep moving it, and those circles keep happening. And I believe that the more we push research and research pushes practice, the better things will happen. Next slide, please. This is the slide that I use at every presentation I do. And it's, what will you do different next week? And I guess, I'm asking that of you today. I don't care if you're a patient advisor or if you're a healthcare professional or who you are, look at what you're doing. And I really want you even to maybe put in the chat, what are some things that you might start doing next week? What are some things that you heard today that you already are doing and you're going to continue doing? And what are some of the things that you might stop doing? Because I believe for everything you start new, you have to stop something, or else you're going to become overwhelmed. And then how are you going to use your own personal experience and knowledge to make a difference, to change what's happening, to change what happens to patients in your beds, to change what they're thinking about at night? And then, I heard Libby say this morning right out of the gate, and I heard her say it yesterday. You don't have to have perfection, but you have to start doing things differently. You have to start thinking about what affects the patient and how does that patient, how is that patient changed because, what makes that, how did they get that infection, and how can you make sure that the next patient doesn't get an infection? How do you make those changes? And then lastly, it's I've heard it from several people in the past couple of weeks that, teams need to be built up. And so one way of building up teams and your team members is asking what matters to them, not just what matters to your patient, but what matters to you, what matters to your team members. Now, many people may ask that of each other that works closely together, but I'm challenging you next week to ask that of a environmental service person or a facilities person, someone in security, someone who you don't work closely with, someone who isn't one of those people that you might think as a healthcare professional, but they are part of your healthcare team, and they are making a difference. And I believe that if you ask them what matters to them and you make a personal connection with them, you're going to change the focus and the vision for the future of your healthcare teams. They're going to be on your team instead of on a team that doesn't, always work together. And I can tell you that as a patient, I know when that team is working together. I know when that environmental service person feels like they're part of a team. I know when that maintenance man that comes into my room to change something or to fix something feels like he's part of the team. I know that because I know how they interact with the rest of the staff. And so, I feel that I understand the teamwork, and all patients do. And then when they understand that everybody's working together for my good or for the good of the patient, they feel that and they heal faster. And so think about that. Think about how you can build up your whole team, not just that person that works next to you or that person that's part of your nursing staff or your physician staff. Next slide, please. So I want to thank you for having Daniel and I today, but I want to give you time to ask questions and to either put a question in the chat and Libby will bring it forward, or I think that's the best way of doing it, right, Libby? Did I miss? The best way of asking questions are in the chat and you'll bring them to us.
Yes, I'm sorry. I would lost my own little control bar. I was so enthralled with moving your
That's
slides
okay.
and listening to you, as always. Rosie and Daniel, thank you so much for such a great presentation. Yes, please feel free to enter your questions in the chat box or raise your hand, and I'll call on you. I think one of the questions that I had was going back to sort of prioritizing your research topics, and you mentioned that there was uh, um, differing opinions about which should be prioritized most highly. And as someone, as a patient partner in several research projects, I feel like that's always kind of the, it's at the beginning, right? What are we going to prioritize as the most important part? And folks come with that initial setup in with different mindsets. So can you tell me a little bit about the logistics of how you worked out those conversations and got to consensus for what you would move forward with as your research priority?
Well, first of all, I'm going to have to tell you, this was not always an easy route, and it got a little messy at times. And at one point, I even wanted to leave the project because I didn't think it was moving forward with any strength, and we weren't meeting with the researchers. And so we as patients were meeting in one, and stakeholders were meeting, and researchers were meeting, but nobody was meeting together. And we kept saying, we want to meet with the researchers. We want to tell them our concerns and our interests. And they kept saying, well, the researchers need to be, they need to be prepared for meeting with you. And I kept saying, well, we are all people. We will all be okay on the same being together. And finally, I literally went to Dr. Nazia and said, I believe in this project. I believe in what we're doing, but I believe that we're not moving it forward. And, I'm going to have to leave this and go to something else because I feel like I'm spinning my wheels. And she said, oh no, Rosie, we need to step back. We need to look at this. We need to all be in the same room. And so she brought us all together in one room, and we literally set up what are the priorities, why are these your priorities? And then we literally went through a process of, what are the top priorities? What things should we work on first? What are the next priority? And by the time we got through with the process, everybody was on the same page. And I have to tell you, from the beginning, the researchers, when we brought the environment forward and we brought forward the things that we had already created, they were like in awe that a group of patients had created this, and they just wanted to. And I remember one of the researchers said, because I have a phobia about wheelchairs. I mean, I never use a wheelchair inside of a healthcare facility. I always bring my own. I have a phobia about how they're clean. And he immediately that night went out and marked all the wheelchairs. And then, and because they had a policy for cleaning wheelchairs, and he believed it was being followed. And so he wanted to prove to me that, that it was happening. And he had to come back to me and tell me that, he marked it on a Friday, and on Tuesday he went back to check the wheelchairs, and 95% of them had not been cleaned. So the mark that he had put on it had not been cleaned off, and it should have been. And so, he said, you were absolutely right. And then that was kind of a turning point. It was like, oh, there's got to be other things that are not happening if wheelchairs aren't being cleaned. But I've literally called facility management people and say, have you ever looked at your wheelchairs? And because some hospitals don't even have a policy for cleaning wheelchairs. It's one of those things that people use all day long, but people don't think about it being a thing that passes germs. People are going in and out of those hospitals in those wheelchairs.
Yeah, it's such a common sight that you don't even see anymore. So,
and usually they put them in the lobby, and then somebody else grabs them, and nobody cleans them.
Right. Daniel, I wanted to just ask you, this has to be a bit of a different way to do research. I mean, the value of research, obviously, in demonstrating, what the problems are in terms of what you shared early on about the impact, the sobering impact of hospital-acquired infections. Was this sort of a different approach to do research with patients and families, and how did that sort of influence you or modify your perspective?
Yeah, so well, this whole thing has been interesting because prior to this I had not been involved in patient engagement research. I was
Mm-hmm.
a pharmacist in graduate school, and then with I would say COVID has kind of disrupted all of what would have been routine procedures, and so
Mm-hmm.
um, it, it's interesting because at this point I haven't had much of a chance to actually work with researchers and patients together because all of our research projects, almost every single one of them, was completely stopped when COVID came.
Oh, oh. Mm-hmm.
Every single one was put on administrative hold, and all the work we were doing pivoted to be COVID centric. And so um, I wish I had more experience to answer your question with,
Yeah.
but at this point, it's really just things are now starting to kind of fire back up, and we have a couple of opportunities to work with researchers coming up on the in the horizon. But um, I guess to your question specifically, um, I am so invested in the patient side of the story that it any reservations I have as a researcher saying like, oh, well, you know, Rosie brought up difficulties with communication with researchers, which I think is really the researchers think it will be difficult to communicate with non-researchers. Um, I I really believe that all it would take is just like what they did. They just put each other in the same room and kind of came to a consensus because I think many of the barriers between engaging patients in research are perceived as opposed to like literal or practical or something like that.
That's a great response. I'm reminded of a researcher a fantastic man, Dr. Michael Rich, and we got into a room and we're not speaking the same language at all. I was talking about Twitter and social media, and he was speaking about variation and all things that I didn't understand. So you're right. Just sometimes getting in and having those conversations is so helpful. And you're really just speaking, both of you, to this culture of safety and engagement and the value. We always say that patient-family engagement is an active strategy. It's the verb that gets us, that produces better outcomes. So it's not, it's just something that can be applied to no matter what you're doing. And Rosie's experience brings that up so well. It reminds me of many a night talking with the EVS staff overnight because they're there, you're there, they're there. And
Right.
yeah, just what a brilliant way to bring that in. So I'm hogging all the time. I think Lori has her hand up for a question.
I do. This is Lori Hensley-Wocheson at HSAG, and I just want to thank you both for sharing your work and stories. And Rosie, I'm sorry to hear of your loss in July. I'm wondering, just following on one of the points that Libby made about the consensus or the journey to coming to topics for the PCORI. I'm wondering, Daniel, you're in a really particular position as a pharmacist, a community pharmacist, and also with the veteran community. If you all have considered or discussed doing some kind of education campaign or some research around the veteran community and antibiotic stewardship.
So that's a great question. And actually, I don't know if many people listening are aware, but the VA itself has been really dedicated to veteran engagement for, well, I believe it started around 2000, as early as 2010, and it really ramped up in 2015. And part of this ramp up was there was a kind of a report convened about how to best engage veterans in research. And one of the largest limiting factors was education. So veterans on average have a difficult time processing the kind of the type of information that is needed to provide feedback on research. And so as of right now, this administrative supplement that we have approved is a very, very, very small part of it is to establish the veteran engagement group. And I would say the other, 3/4 of it is going to be specifically dedicated to educational outreach to veterans. And I actually I'm not privy to whether that is focused on antibiotic stewardship or not, but I think that is extremely important and definitely something that our group will be looking into going forward.
I have to
It's
tell you that
exciting.
from the group, the Parkoria grant, we took $20,000 of that and did radio ads with Heart Radio and created radio ads. And one of them was on antibiotic stewardship. One of them was on C. diff. One of them was on, I think there were like 4 different ads. One of them was on patient engagement, but basically saying, what is it like to have C. diff? Why is antibiotic stewardship important? And I thought when they took that money and said we were going to use it for it, I was not impressed with it. I was not for it. I did one of the ads because they asked me to do it, but I have to tell you that those ads still come up sometimes, and people say, "I heard your C. diff ad," and I'm like, "What?" And because that radio ad hit all parts of the country through Heart Radio, it was used all over, and it's still being used. So, sometimes something that I thought was radio, why radio, but radio for, especially the VA and some of those sectors, it was a great use. And especially in some of our rural areas, radio was a great place to start.
Fantastic. Any other questions or comments for Rosie and Daniel?
By the way, we did spend some money on C. diff. We didn't wipe out the researchers completely. And I have to remember, I always tease about this because the guys in the group, because the research we did was on, vancomycin is one of the treatments for C. diff. But if that doesn't work, one of the other treatments is transplant.
Microbiota, fecal microbiota transplant.
Transplant. And there's various ways of doing that. And then they also have, instead of blood banks, they have, as David would say, poop banks. And so David was like, the guys in the group were like, there is no way we should be doing this research. But we did spend some money on that. And UW did do some work and is continuing to do some work on fecal transplant and some ways of using fecal transplant for people where vancomycin does not help C. diff. And I have to tell you, as a C. diff person and a person who had C. diff, drinking vancomycin isn't a treat either. So, and I kept saying, if you've never had C. diff, you won't understand this. But if you had C. diff, you'd do anything to get rid of it, and I mean anything. And so, fecal transplant was not a horrible way of looking at it for me. It might sound terrible to other people, but if you've had C. diff, that was minor. If it was going to help it was going to make it go away, I was going to do it.
So I think this has been just such an incredible conversation and really eye-opening for me. I'm thinking about EVS in a whole different way, and that staff and how we empower the team, right? We all know healthcare is a team sport, but are there other team members that we've traditionally not remembered to bring onto the team? And when I think about all the work we've done through CMS and the Hospital Engagement Network and the Hospital Innovation Improvement Network to reduce hospital-acquired infections and C. diff and all of these. And how much of that work have we included the EVS? It just, I'm not sure that we did as much as we maybe could have. And so I guess with our last few minutes here, I just want to thank you both for a great presentation, very thought-provoking. So I'd like to ask the participants, if you would, please chat into the chat box again so that we can capture all of your ideas and insights from this session, and share broadly with those who weren't able to make it today. What is that one idea or insight that you're taking away from our presentation today? I'll ask you just to do that for the next minute or two into the chat box. I'm gonna put my own in. Right, there's mine. Rosie, Daniel, any final thoughts?
My final thought is that during this COVID time, their environmental service people have worked diligently to help make sure that, the environment is clean, and I think they're tired and sometimes very stressed. And so reaching out to them, saying a thank you to them is very important. And I mean, even as patient advisors, we've sent messages to other people. We need to make sure we send messages to them. I know I did that with environmental services for some of the hospitals I work with, and they were elated, and because nobody had reached out to them and nobody said thank you to them.
Yeah, I would definitely echo what Rosie's saying. I think that there are many thankless jobs in healthcare, and recognizing those people and acknowledging them only improves the care that subsequent people will receive. I think that, especially in a time like this where it's so stressful too, like just reaching out to other people and thanking them for things is incredibly helpful. And then lastly, because I have to as a pharmacist, remember to get your flu shot.
Yes, flu shots, everybody.
And Daniel was the person who told me this morning. I shared your story, Daniel, about curbside flu shots, because I think that's a cool idea.
Cool idea. It's a bit chaotic in practice, but it's working so far. Yeah.
Excellent. Well, thank you for your service to your community, Daniel, and Rosie, as always. Sharing your story creates impact and sparks ideas and innovation. And for those of you interested, I will just let you know that Rosie did write a book that was published shortly before David left us and is out if you want to know more about Rosie and David's story.
And you can email me and I can send you the way that you can get the book.
Perfect. All right. Well, thank you so much for joining us, everybody. Today, let's get off this Zoom and get on to our other Zoom so that we can put all that we've learned over the last 2 days into an action plan for each of our health systems and for our own. Each of us, I am such a firm believer, each of us has a unique contribution to make to improving healthcare, the quality, the safety, and the experience. So let's get on over to our final session and figure out how we're going to do that next week.
Okay. Thank you, Libby.
Thank you.